Hello. First of all, I would like to thank Dr. Siham for this opportunity, and of course the whole DEOSS team and Dr. Shetty for this wonderful meeting. So I'm going to present two challenging cases that I encountered in clinic, and they are touching up on subjects we already discussed. So the first case is a 47-year-old man who presented with marked discomfort and progressive visual loss in both eyes, the left affected more than the right. His past ocular history was significant for chronic conjunctivitis since childhood. It was very severe with a lot of redness, tearing, and progressive scarring. He saw multiple doctors, including immunologists and rheumatologists, to rule out atopy as a cause or a rheumatologic disease. He underwent many treatments with only transient improvement. Now, on exam, his vision in the right was 2100 and in the left was 2400. This was his right eye. There was significant injection. There was scarring on the cornea. He also had meibomian gland dysfunction, lid thickening, telangiectasia, and a lot of staining all over. In the left eye, the picture was even worse. He had the descematocele. He also had a lot of scarring over the cornea and thinning. He had symblephara inferiorly only, sparing the superior part with a lot of injection. And this is another basically picture of the inferior conjunctiva in the left eye. So superiorly, there was only injection. This is the OCT MS39 of his left eye with the descematocele. When we stained with fluorescein, which was mentioned many times, there was zero tear film. It was completely dry, no tears whatsoever. So this was a case of a long-standing chronic conjunctivitis with the left more affected than the right since childhood, multiple lid surgeries, and by the time he came to me, he was on systemic immunosuppression, methotrexate, he took prednisone, and then he was switched to biologic with a little bit of improvement. Of course, also before coming to me, he had a biopsy taken and it was negative for ocular cicatricial pemphigoid. His whole rheumatologic workup was also negative, and an MRI also showed nothing remarkable. So, as a plan, we were treating him for immune cicatrizing disease, most likely OCP. Could be a result of severe atopy in childhood. He is still on immunosuppression. Topically, he's on intensive lubrication, on cyclosporin, on PRP eye drops. I even did an injection in the lacrimal gland. And he also has CME for which he's treated with steroid and NSAID. He underwent, right before I came, lysis of his adhesion and buccal mucous membrane graft in the left eye. And now I'm planning to do an amniotic membrane graft with limbal stem cell transplantation and PKP. And any suggestion is welcome. So we looked at the literature for OCP. It affects 1 in 10,000 to 50,000 individuals, women more than men, 2 times more. 40% of patients will have a negative biopsy, and only 10% will not have any oral symptoms. He doesn't have any oral symptoms. About the PRP lacrimal gland injection, it was discussed, and actually I learned about it last year in the DEOSS meeting, so I will let you know if he improves. And that's where we're at now with the first case. The second case is a 52-year-old man patient who presented to clinic with a corneal perforation in the right eye following a phacosurgery done outside 6 weeks prior to presentation. So he was sent to us. His medical history was positive for presumed cerebral palsy, and he was on a wheelchair, coming with family members. Upon arrival, we took cultures that were negative and we started him on moxifloxacin eye drops, awaiting a tectonic PKP. He used them every 2 hours. On exam, in the right eye, he was counting finger at half meter. In the left, 2150. He had lid changes, typical of severe MGD with thickening and telangiectasia. In the right eye, he had 2 large inferior perforations, which were plugged by iris, and he had a contact lens in place. In the left, he had an inferior 1.5 millimeter scar, but that wasn't, there was no defect overlying it. The anterior chamber was flat in the right and deep and quiet in the left, and he had a PCIOL in the right and a little bit of cataract in the left. So this was his very complicated course. When he came, he had the perforation. We did the first tectonic PKP. Directly after, he had a very early graft decompensation with a superimposed infection, needing resuturing. He had a corneal melt and a second tectonic PKP. With a recurrent melt as well, a lot of inflammation, a lot of secretions, and so I had to do a Gunderson flap. This is the images of this right eye. It was a very quickly progressing situation. In the meantime, his left eye started having ulcers, many sterile ulcers, and in many different central locations. And this is his left eye OCT. Now, this is what the patient looked like. We asked about a rheumatologic workup. They denied, the family, but we still insisted on sending him to rheumatology, which was discussed earlier, how important is the communication between us. So he went there, he underwent tests, and because he had the recurrent sterile appearing melts, the severe dryness and multiple joint problems, his results came back positive, ANA positive, rheumatoid factor elevated, anti-CCP positive, ESR-CRP elevated, and anti-Rho, anti-La negative. So this, the diagnosis was advanced seropositive rheumatoid arthritis with secondary Sjogren, and he was started on methotrexate, then adalimumab. He had marked improvement, but it actually took a while for him to respond. In the meantime, we were giving him aggressive lubrication with PRP drops. He was also using lubrication, and on last visit, his right eye is still stable, and the left is it's doing very well. He's not staining even anymore, and we're awaiting to do a cataract surgery. So this is secondary Sjogren, and secondary Sjogren in rheumatoid arthritis occurs in about 8.7% of patients, and the positive anti-Rho, anti-La, the anti-Rho, anti-La are only positive in 26.5% of patients. In a study that looked at rheumatoid arthritis patients with secondary Sjogren, 25% had extraglandular ocular involvement, and 13% of patients had vision-threatening ocular complications. So the take-home message is that even if we have a negative biopsy, for example, we are still dealing with a cicatrizing disease that requires immunosuppression. Systemic control is very important in cases we have to look beyond the eye. We have to communicate very well with other physicians, and multidisciplinary care is very important in these patients to save their vision. Thank you.